Excuse me, Mr. McDaniel?
Oh, hi, Marissa. Beth, I'll follow up with you in a little bit. What can I help you with?
My patient, the one who has a tracheostomy and is on a ventilator, needs to be suctioned, I think.
Well, I'm glad you came to me about this. So tell me what the problem is.
Well, I listened to his breath sounds and heard wheezing and crackles, and he's gurgling a little. His oxygen saturation was 93%, which is decreased from the previous measurements.
Okay, I agree. Suctioning his airway via the tracheostomy will remove pulmonary secretions and improve ventilation. Now, the goal when suctioning the airway is to remove secretions that aren't accessible to cilia bypassed by the tube itself. But what are some of the risks of tracheal suctioning?
It can lead to hypoxemia, cardiac dysrhythmias, trauma, atelectasis, infection, bleeding, and pain.
Right. So you need to be careful to maintain aseptic technique and to follow all facility guidelines and procedures to prevent potential hazards. You also have to be careful with insertion of the catheter. How far do you insert the suction catheter into the tracheostomy?
I think it's no more than 1 centimeter past the length of the tracheostomy or endotracheal tube. Is that right?
Yes, that's correct. Now, for equipment. Because your patient is being mechanically ventilated, facility policy directs the use of an inline closed suction system.
Closed systems are helpful for patients who may need to be suctioned frequently or quickly.
That's right. Very good. Okay, we'll need to check the patient's record for the size and length of the tracheostomy tube, verify the suction order, and get our supplies. Now, what emergency equipment should already be accessible at the bedside?
That would be a bag valve mask, oxygen, the obturator from the current tracheostomy, a spare tracheostomy of the same size, plus a tracheostomy 1 size smaller.
That's right. Okay, well, let's get the supplies and go see your patient.
Okay. Mr. Boyd? Hi, I'm back. It's Marissa, remember me? And this is my instructor, Mr. McDaniel.
Hi, Mr. Boyd.
I know you can't speak because of your tracheostomy, so can you just nod yes or no to respond to my questions? Does that sound okay? Okay.
Mr. Boyd, we're going to make it easier for you to breathe by suctioning your airway through your tracheostomy. Is that okay with you? Okay, good.
So I'm going to be doing an assessment and a few other things before we do. First, can I double check your ID band? Thanks. And your full name is Marvin S. Boyd. And your birthday is January 12th, 1948. Great. Thanks, Mr. Boyd. Now, before I get started, are you in any pain? Good. Did you experience any pain the last time the nurse suctioned your airway? Now, if you did, I would perform individualized pain management.
That's correct.
Now I'll make sure to announce each of my actions aloud so you know what I'm doing. If at any time you have pain or feel bad in any way, signal me and I'll stop right away. Now let's agree on a hand signal. How about if you raise your left hand in the air like this? Can you do that for me now? Great. So you understand that signal from you means I should stop doing what I'm doing. In addition to any pain, you should let me know if you're feeling any difficulty breathing. Good.
Okay, great, Marissa. Now let's get set up, okay? And then put Mr. Boyd into a semi-Fowler's position. Now, if he were unconscious, you would place him in the lateral position facing you. Now, bring the overbed table and trash can closer. Good. What's next?
Get my supplies ready. I assess his respiratory status, lung sounds, and oxygen saturation, right?
That's right.
Okay, Mr. Boyd, I'm going to listen to your chest to check your breathing. Okay, pretty much the same as I said before. Crackles, wheezing, oxygen saturation 93%.
Okay. Next, you're ready to turn the suction unit on and to the appropriate pressure.
Let's see, a wall unit for an adult patient should be 100 to 120 millimeters of mercury, right?
Right.
Okay.
Now, place a waterproof pad on the patient's chest under the tracheostomy. And now open the package of the closed suction device using aseptic technique.
Just like we discussed, I need to make sure the device remains sterile.
That's right.
So next I put on gloves and a face shield. It's important to work quickly and be careful to avoid contaminating open ends of the equipment. So I disconnect the ventilator from the old suction device. Okay, I now remove the old suction device from the tracheostomy and replace it with the new one. So that the suction catheter is in line with the tracheostomy.
Very good, Marissa.
And next I attach the ventilator tube to the port.
Perpendicular to the tracheostomy tube.
Okay. And I remove the suction tubing from the old device and attach to the suction catheter. Then I open the plug to the port by the suction catheter and insert the saline, right?
That's right. Okay. Now we'll temporarily silence the ventilator alarms and push the 100% oxygen button on the ventilator. Can you tell me why we do that?
This will temporarily increase the amount of oxygen the patient is receiving while we suction his airway.
Good. Now, grasp the suction catheter through its protective sheath about 6 inches from the tracheostomy and gently insert the catheter into the tracheostomy tube. And release the catheter while holding on to the protective sheath. Now, move your hand farther back on the catheter, grasp the catheter through the sheath, and repeat the movement, advancing the catheter to the predetermined length, in this case, 10.5 centimeters. This will prevent contact with the trachea and carina, reducing the effects of tracheal mucosal damage.
Remember to raise your arm if you have any discomfort. Now I'll apply intermittent suction by depressing the suction button with the thumb of my non-dominant hand as I withdraw the catheter.
Good. Now remember, don't suction for more than 10 to 15 seconds at a time.
And as I withdraw the catheter, I gently rotate the catheter with the thumb and index finger of my dominant hand. This helps clean the surfaces of the respiratory tract and prevents injury to the tracheal mucosa.
Now once the catheter is withdrawn back into the sheath, depress the suction button while gently squeezing the normal saline until the catheter is clean.
Okay, it looks clean.
Allow a 30-second to 1-minute interval if additional suctioning is needed. No more than 3 suction passes should be made per suctioning episode. Why is this?
Well, allowing intervals helps compensate for hypoxia caused by the suctioning.
That's right, and excessive suction passes contribute to complications.
I think we're good. What do you think, Mr. Boyd? Feel better?
Okay, so now what?
I make sure the catheter is withdrawn into its sheath.
And turn on the safety button, remove the saline, and apply the cap to the port.
Turning the safety button blocks the suction at the catheter, so the suction can't remove oxygen from the patient's airway, right?
That's right. Check the alarm and oxygen setting on the ventilator. They time out and return to the original settings after being paused. Now, you should suction the oral cavity with a separate single-use disposable catheter. This removes any stagnant secretions from the mouth and pharynx to reduce the risk for infection. Then, perform oral hygiene to promote patient comfort.
Okay, Mr. Boyd, can you open your mouth for me? There we go, Mr. Boyd. All done. Let's dispose of this, and I'll take off my gloves. Now let's get you into a comfortable position.
Okay, very good, Marissa. Now raise the bed rail and place the bed in the lowest position. Okay, now reassess the patient's respiratory status one last time.
Okay, can I take another listen, Mr. Boyd? Lungs clear, no wheezing, oxygen saturation 99%.
Good. Now finally, let's document. Okay, now remember to document the time of suctioning, your pre- and post-intervention assessment, the reason for suctioning, oxygen saturation levels, and the characteristics and amount of secretions.
Okay, all done. Now, Mr. McDaniel, is there a certain frequency for suctioning a patient's airway, and should I plan on coming back at a certain time?
Well, frequency is based on clinical assessment to determine the need for suctioning. Suctioning is indicated when pulmonary secretions, blood, vomitus, or foreign material are interfering with a patent airway.
Okay, that makes sense. Okay, Mr. Boyd, do you have your call bell? Here you go. Can I get you anything else before we leave? Okay. Call if you need me, and I'll be back shortly.
Thank you, Mr. Boyd.